To go.
Okay, you're live.
Well, welcome to everyone to the Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies. It's our final webinar in our fall webinar series that focuses on the state of the primary care workforce and how nurses can help improve the delivery of primary care. We're very pleased to have all of you joining us on this webinar today. And my name is Peter Bierhaus. I'm the director of the center, and you'll hear later from Christy Friedman, who is the program manager for the center. So Christy asked me to do all the heavy lifting at the beginning of this webinar, which means giving some announcements here at the top. So first of all, some of you may have attended our prior webinars in October that discussed the Macy Foundation's recommendations for expanding the use of registered nurses in primary care. And others may have attended last month's webinar that described how a large community healthcare clinic in Connecticut uses registered nurses to provide primary care in novel ways and in interacting with a large interdisciplinary team. Now, we have recordings of both of these webinars, and you can listen to those if you go to our website and look under the tab Video Library. So after today's presentations conclude, we'll have about 15 to 20 minutes for discussion and questions and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of these questions as we can. We have a few other announcements, then I got a little bit ahead of myself here, and that is regarding that on our I'm sorry, I'm doing Christy's script, everyone, and I'm not used to this, so I'm just sort of finding myself around here. We've got a busy lineup for webinars coming up in the new year. First, we're partnering with the Center of Health Workforce Studies at the University of Albany at the State University of New York and their Health Workforce Technical Assistance Center. We're going to organize 3 webinars in January, February, and March that are focused on state-level nursing data collection, analysis, and dissemination. Now, these webinars are designed to help stakeholders better understand the major challenges facing the nursing profession and the strategies used to support nursing workforce data collection at the state level, analysis, and dissemination. So you can RSVP for these events and read more about them in our upcoming announcement and blog posted on our website. Also in 2017, our center is partnering with the University of Michigan's Behavioral Health Workforce Research Center to provide 4 webinars focused on the latest research, data, and trends in the behavioral health workforce. These webinars will run monthly from February to May, and again, we'll have information in our January newsletter and also on our website. So in case you missed it, we've posted some new regional forecasting research on our website. The research is titled, How Fast Will the Registered Nurse Workforce Grow Through 2030? And projections in 9 regions of the country. Now, this is available in the online version of the journal Nursing Outlook, and we expect it will be published in the January-February issue in the journal Nursing Outlook. We think that'll be due out in about the 3rd week of January. The purpose of that study was to understand how the outlook for growth in the future number of RNs over the next 15 years varies regionally across the United States. And we apply our nursing supply model to these 9 U.S. Census divisions to produce separate region-specific forecasts. And we find really quite dramatic differences in expected future growth of the nursing workforce across the regions. And folks on the East and West Coast, look out. You might want to take a look at this, this manuscript. Finally, I know the holidays are fast upon us, but it's not too early to be thinking about summer 2017. And that means we need you to save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers Conference around the nursing workforce and health reform, trends and opportunities in a new political era. The conference is being co-organized by our center here in Montana. It'll be held in Denver at the Grand Hyatt Denver on June 7th through 9th. And again, look for more details, including the call for abstracts, sponsorship, and registration information, all coming soon, very first part of January on our website. So again, now I'll say this part. After today's presentation concludes, we hope to have about 15 to 20 minutes for discussion and questions and answers. So type in any questions you have in the area designated for questions on your menu bar, and we will get to as many of these questions as we can. We're recording today's webinar. It will be posted on our website very, very soon. We've got almost all of our webinars posted on the website, so you can find the event calendar tab on the website. So I'm going to go ahead and begin to introduce our three speakers today, but I just want to tell everyone that out here in Montana, winter has arrived, and I mean winter. We've got snow, cold, and more cold coming. The temperature will fall to below 20 degrees below zero overnight on Friday. So graduation ceremonies on Saturday morning should be pretty exciting. All right, now to our three speakers. First, Dr. Ellen Marie Whelan will lead off our webinar. She is the Chief Population Health Officer for the Center for Medicaid and CHIP Services that provide clinical input and guidance for the health coverage of over 70 million people served by Medicaid and CHIP. Ellen Marie is also a senior advisor at the Centers for Medicare and Medicaid Innovation, coordinating the pediatric profile across the center. So both of these positions, Ellen Marie assists in the design, implementation, and testing of delivery system transformation and payment reform initiatives. Now, prior to this position, Dr. Whelan was the Associate Director of Health Policy at the Center for American Progress, and she's done previous research and lots of publications and speaking engagements, much of it focused on the development and passage of the Patient Protection and Affordable Care Act, system delivery and payment reform, safety net providers, primary care, and healthcare workforce policy. Following Dr. Whelan, we'll hear from Dr. Danuta Wojnar, who is an Associate Dean for Undergraduate Education and a professor and the Endowed J. Bushman Chair in Nursing at Seattle University College of Nursing. Danuta's responsibilities include assisting faculty in curriculum design and implementation and evaluation of program initiatives. So over the years, or the past year actually, Danuta led the implementation of primary health care curriculum that encompasses threading population health and primary care concepts in all didactic courses. Moreover, using a very collaborative approach, she has developed partnerships with community-based healthcare sites to offer a quarter-long clinical rotation in primary care for every undergraduate student. Our final presenter is Dr. Beth Ann Swan, who is the Dean at the Jefferson College of Nursing and Senior Fellow in the Jefferson School of Population Health at Thomas Jefferson University in Philadelphia. Dr. Swan is a Fellow of the American Academy of Nursing and has been the past president of the American Academy of Ambulatory Care Nursing and is a 2007-2010 Robert Wood Johnson Executive Nurse Fellow, as was Danuta. Dr. Swan was a member of the Veterans Health Administration Choice Act Blue Ribbon Panel and was a member of the Josiah Macy Jr. Foundation Planning Committee for preparing registered nurses for new roles in primary care. Beth Ann has served as a member of the Steering Committee of the National Quality Forum for standardizing of ambulatory care performance measures, and is currently a member of the Care Coordination Steering Committee for the Care Coordination Measure Endorsement. So I've shortened the introductions of all our speakers, but we could spend another few minutes talking about how well qualified they are to give our webinar. So without further ado, I'm going to toss the microphone back to you, Christy, and take it from there.
Great. I believe Ellen Marie is going to kick off our presentation. So whenever you're ready, Ellen Marie.
Thank you so much. Thank you, Christy, and thank you, Peter, for inviting us to join your series of webinars. I'm here in DC, and we feel like winter has arrived because it just hit 32 degrees, and we're all freezing out here. So we have nothing to compare ourselves to when we think about what Montana is like. Christy, I'm just going to go a little bit out of order. Would you mind going ahead to slide number 5, and then we'll jump back?
Sure.
Thank you. So we're going to talk today. I understand that you've heard from others about the work that the Macy Foundation did on exploring the role of the RN in primary care. And so we're going to talk today about how we think this is happening in some of the opportunities for schools of nursing. One more. Christy, one more slide. Thanks, that's perfect. So just a bit of an overview, just to make sure that we kind of do a little bit of context or level setting. I'm not sure who participated in all of the webinars so far, but I've certainly been interested in the role of the RN in primary care for many, many years now. I'm a nurse practitioner by training, but have long thought about the importance of the role of the RN in primary care. And we thought that this was particularly important at this time for a number of reasons. I think probably everyone on the call knows that the amount of money that we as the United States spends on health care doesn't correlate to better outcomes in many situations. In some high-tech situations it does, cardiac transplants, et cetera, but for a lot of the basic health indicators, we as a nation do far worse than other nations internationally who spend a lot less on healthcare. In part, they're spending more on some of the social issues, but we realize we're just not getting the bang for our buck. So this acknowledgement is not new. We've known this for a long time, but there's 3 general reasons that we were thinking that this was really prime time to be thinking about why the RN in primary care might be an interesting path forward. First of all, as we are acknowledging kind of how we can improve healthcare generally, and this really is nothing political, this really is just how we can do a better job. There's been a movement away from fee-for-service. Fee-for-service in many instances was just a reward for doing more volume and not paying as close attention as we think we could to the outcomes. Are people actually getting healthier? And in that reconceptualization, there's been an increased focus on primary care, or actually primary health care is the way that many of us are thinking about it. Lots of providers, especially in rural areas, are paying closer attention to the delivery of primary care with an acknowledgement of some of the other social issues that are critical to keeping folks healthy, whether or not there's housing, whether or not they've got access to food, better understanding children's readiness for kindergarten or reading or actually graduation rates. So all of the things that go into making an individual healthy. So this focus on primary care is putting a strain on the primary care delivery system because there's probably not enough capacity out there to serve everyone. It's also, as you all who look at workforce issues realize, it's not reimbursed the same as folks that are working in acute settings. The second issue that we think that this is a really important reason to be looking at the role of the RN in primary care is because of our aging population and a population that has become increasingly chronically ill. Right now, we as a nation spend 85% of our healthcare dollars. So 85% of all the dollars that we spend in healthcare goes to treating people with chronic conditions. And we know that folks with chronic conditions, it's usually a failure of the health, it's oftentimes a failure of the health system when they ultimately need to be going to an emergency room or hospitalized. Much of what needs to happen to keep a chronically ill person healthy happens at home, in the workplace, perhaps in the school, all sorts of settings that are not typically considered an acute care setting. So the fact that we're moving and looking at different ways of delivering healthcare, perhaps outside of the traditional clinical settings, is the second reason that we thought this is so important. And third is, of course, workforce changes. And that's what you all have heard lots about through the series of these webinars and understanding the numbers You've got Dr. Bierhaus here, who has been leading the nation in better understanding. Do we have a shortage of physicians? Are they just in the wrong area? Do we have a surplus or a shortage of nurses? How are we better using the entire healthcare delivery system? How are we looking at using non-licensed professionals like clinical community health workers or promodoras? So given these changes, this seemed to be just an opportune time to be able to look at exploring the role of the RN in primary care. So now I'm just going to do a brief context to the paper that Danuta Wojnar and I did. It's in Nursing Outlook, and we can provide a link to that if folks are interested. And I'll just do a couple slides as a brief and then move the agenda onto Danuta. So can you go back to slide number 2? The question lots of folks asked when we started to talk about the role of the RN in primary care is this really where, that's perfect, thanks. Is this really where nurses belong? And of course, if we have a nursing audience on the line, many of you will acknowledge that this is really the basis of nursing. The historical context of how nursing started was very much in a primary care or a primary health care or a public health aspect. Florence Nightingale was looking at epidemiology in the Crimean War. She was looking at all sorts of really broad issues that affected the health of the individuals that she was serving. And we loved these two quotes here. Money, that she said ages and ages ago, money would be better spent in maintaining health in communities rather than building hospitals to cure. And the second is the health of individuals is almost inseparable from the health of communities they live in and the health of the communities of the overall health of each nation. So clearly a visionary and way ahead of her time, and we still strive to kind of keep up with what she pursued there. The next slide, just a bit of historical context that back in the early 1900s, the very basis of nurses again was in a public health primary care setting. The district or visiting nurse, Lillian Wald, was a champion of this kind of nursing at the turn of the century. And actually up to 1939, nearly all of the nurses in the United States were in district or visiting nurse or home visiting. 200,000 were in this kind of home-based setting, and only 2%, 4,000 nurses were in hospitals. And of course now it's completely reversed. We've got, with the dawn of insurance and having insurance pay for acute care, that movement has gone into the hospital. The next slide, the purpose of the study that Danuta took the lead on, and she's going to walk through what she found. 3 things. We wanted to explore how nursing education is currently incorporating primary care into their current curriculum. The second was describe what kinds of opportunities and challenges that schools would have, including primary care into their pre-licensure nursing education. And last, what were some of the changes that we would propose that would enable a primary care content, both in the didactic and sometimes even more challenging in the clinical settings. So now I will turn the slide over to Danuta. And so we'll go to slide number 6.
Thank you, Ellen Marie. And before I start, I wanted to acknowledge Robert Wood Johnson Foundation. They sponsored this research study as part of the Executive Nurse Fellowship that we were, both Ellen Marie and I were in the same cohort, and that's how it was sponsored. So let's just go to methods now. So of course, before we conducted the survey, we obtained permission to conduct the study, actually from Seattle University IRB, where I work, and we sent electronic survey to over 1,400 schools and colleges. The majority were BSN programs, nearly 700, and master's entry to practice program. And in this program, students go, for those of you who may not know, in very expeditious way to earn their RN, and then they go on to master's rather than to stop at BSN level. We also sent surveys to 632 associate degree in nursing programs. And for the RN to BSN programs, we were curious if there is any curriculum that addresses primary care. We picked 100 top programs, and then we send the survey to them as well. To analyze data, we use summative content analysis, and the whole goal of the analysis was to identify any curricular changes that would be nationwide recommendations, and we wanted to know about the state of the teaching this content in both didactic and clinical programs nationwide. Next slide. Next slide, please. Okay, so as I said, like we sent way over 1,000 surveys, and we had a return rate of 37.5%. Over 500 completed surveys were returned, and the majority came from university-based pre-licensure programs. We received 302 completed surveys back, so the response rate was almost like 45%. From the associate degree programs, we received 173 surveys, so the response rate was lower, under 30%. And then from the RN to BSN programs, the 100 top programs that we sent the survey to, we received like 48 back with 48%. What we found is that many universities, from the surveys that we received from those who participated, implemented at least some primary care content. And many of them integrated it excessively, but only 20 integrated or in the process of integrating it across the curriculum. Next slide. And what we looked at, as I said, is the facilitators. And the key facilitators to implementing the primary care content in nursing curricula were, first of all, visionary leadership. That's what we did hear from all participants, and also forward-thinking faculty. So we are the drivers in higher education, in pre-licensure programs, and it's like up to us that this change can even happen. Also, it was like very important, like participants pointed out that they are inviting and collaborative community partners. If there's no community clinics and other primary care practices that want to collaborate, it's impossible to implement it. Also, like people identified that they were aware of the current trends in healthcare. Ellen Murray spoke about it like already. So faculty nationwide do recognize that because of the current trends, because of the expenditure for healthcare in the acute care, in inpatient settings, to maintain the level of care and improve population health, we need to go back to community-based care. Also, in places where there was improved access to interdisciplinary education, and that was nationwide, where the clinical performance labs were very well set up and students could learn collaboratively and learn the team approach to care very early in the program, it was seen as facilitator. Likewise, the recognition of the importance of primary content. So if faculty were up to speed on what is important and how it improves and supports population health, then that was seen as facilitator. In some states, there were also like mandates from state nursing commissions. It's not nationwide, but there were some who acknowledged that they are moving this way because they already got recommendation from the states that they changed their curricula to include primary care. And moreover, there was also recognition that there is a growing number of openings for registered nurses in community clinics and other primary care sites, and some people are very interested to participate in that kind of care provision. Next slide. There were also challenges that we found in our survey, and that comes from across the nation. So the key challenges was, like, of course, like before, like I said, that the facilitator would be like forward-thinking faculty and also excellent leadership in the colleges and schools of nursing. The challenge is that the faculty are not interested. And when there is no like buy-in, then of course it trickles down. The students feel it, community partners feel it, and it's difficult to make it a reality. Also, and that is like very real, like I lived through that as well, it's that sometimes, depending on the location, there may be too many students that need these opportunities, but too few sites where they can have meaningful learning opportunities. And in that case, it is really difficult, especially there were some survey participants like who were from smaller communities, and they would say we just like do not have facilities to which we could send our students, and then they focus on community care. Then also another very real challenge is when there is lack of registered nurses to serve as preceptors in the primary care sites and to be role models. Like there are still like so many practices across the country that utilize other staff. That is also very important, but there is no registered nurse on staff to actually teach what that role could be like. Clinical coordination was also a challenge, and it was stated by many as very expensive adventure, and many people, like maybe not using the exact words, but stated that it can be an administrative nightmare to be able to coordinate the students, because many practices are only able, for instance, to take one student at the site, and then it was like difficult to coordinate, and faculty had to travel like all over the place. Also, like from many respondents, like we did hear that students were pushing back, and they were fearing that they are going to lose out on skills. So in many curricula that traditionally in the undergraduate programs in the pre-licensure, both ADN and BSN curricula, the focus used to be for years on acute care and inpatient. So many students like would come with the belief that they would be trained to become nurse in acute care setting. And then like they were fearing that these new skills maybe were insufficient, like if they were not interested in that kind of learning. Also, sometimes there are community expectations and like what people believe in general. So that was like one of the challenges or limitations. There was a number of respondents that also they mentioned that primary care content is not generally tested on NCLEX. Thus, it's not believed to be important. So the bottom line for the student is like to pass NCLEX, and for schools as well, so they maintain being open. And that was seen that may be unimportant, like if we don't include that on NCLEX. So that takes me to some resulting opportunities. As with everything still new, and this is new in life, there are challenges and there are opportunities. There is a steep path ahead to overcome the challenges for all of us nationwide. And the path is steep because like of the challenges that were mentioned from across the nation. So in order to facilitate change, schools and colleges of nursing will implement some changes, like to make it meaningful and to actually prepare students. First of all, like we need to think about the necessary revisions to curricula to include primary care. And that is true for the didactic courses and for clinical courses. And faculty buy-in is just absolutely necessary and important. That can happen through continuing education, not only in academia, but also continuing education on primary care for registered nurses that are already in practice. there is a need to expand interprofessional education, so we can be all in it together. And there's a very important need, like, for synchrony between education and practice partnerships. And if you have questions after, we are very happy to address them. I'm very happy to talk about challenges that we have experienced here in Seattle as well. It is very important that registered nurses, for the reasons that we know from already available evidence and from the studies that were conducted in thriving primary care practices, that registered nurses, when included in primary care nationwide, have very important contribution to the success of healthcare. And we have to disseminate both our successes and challenges, so other people who have not tried that yet are not going to repeat maybe the mistakes that those who were first experienced, and disseminate the knowledge to encourage others. So that concludes my presentation, and I'm going to turn it on to Mary Beth Ann. Sorry.
Great, thank you so much, Danuta. Give me just 1 second here. I'll get us changed over. Okay, Beth Ann, whenever you get ready.
Okay, you can see my slides?
Yep, they look great.
Yes, we can.
Okay, terrific. All right, well, again, I want to thank Peter Bierhaus and Christine for this opportunity to share some work that we're doing at the Jefferson College of Nursing. So we're excited to share an opportunity, our initiative, an exemplar of nursing education focusing on didactic and clinical opportunities for primary care to support student learning and to improve care for individuals and families. So the Jefferson College of Nursing at Thomas Jefferson University designed an innovative, forward-thinking 21st century baccalaureate nursing concept-based curriculum. And this was a faculty-led initiative and is based on One Jefferson's mission: health is all we do. And the Jefferson College of Nursing curriculum for health, we say, is HERE, H-E-R-E, humanistic, evidence-based, reflective, and excellence in clinical leaders. And the curricular framework that guides the newly designed concept-based baccalaureate curriculum is promoting health and quality of life along the care continuum. And this framework emphasizes the promotion of health and quality of life in a variety of populations during transitions of care from one setting to another, and is guided by the curricular themes of innovation, population health, interprofessional collaboration, and practice excellence. So central to the curriculum is the need to leverage partnerships to support the newly developed course offerings, immersion experiences, which we formerly called clinical, service learning, and experiential opportunities across the care continuum, from acute care to primary care, ambulatory care, home care, and as we say, wherever care may be delivered in communities. And these partnerships are mutually beneficial to promote health and foster cross-sector collaboration to improve well-being. And the curriculum for nursing students' didactic content and immersion experiences is more closely aligned with the evolving role of registered nurses beyond the hospital walls in both primary care and ambulatory care. And students engage in integrated didactic learning and immersion practicums that promote a culture of health and multiple new and emerging roles of RN rather than a disease-based, acute care-focused curriculum. Nursing students learn content related to safe and effective care services delivered in primary care, ambulatory care, and community settings at the point of living, preparing them with knowledge and skills in care coordination, chronic disease prevention, population health, and team-based interprofessional care. And specific courses address health promotion across the lifespan, professional practice, discovery and evidence-based practice, healthcare informatics and innovation, population health, cultural awareness and health disparities, care coordination and care transitions, and clinical reasoning. So in practice, healthcare delivery is changing with a focus on population health, health promotion, and clinical prevention. And national reports such as the Robert Wood Johnson Foundation Research Brief describes nursing in a transformed healthcare system, new roles and new rules. Also, there's trends in healthcare and nursing practice must be considered in how we educate new nurses. And also the Institute of Medicine's Future of Nursing recommendations guides both our thinking in transforming curricula and education as well as practice. So to begin this creation, this transformation of our baccalaureate curriculum, we started with a blank slate. And we explored the idealized design, the characteristics, the skill set of a BSN graduate with our practice partners. And this is the list of characteristics that our practice partners identified. We also completed focus groups with current students and alumni to gain information about their experiences as new to practice nurses and to introduce the thinking of person-centered care rather than patient-centered care. So with a focus on wellness and health promotion, disease prevention, we are working with and partnering with individuals, with people who are not patients. So we aligned all this information to identify the interpersonal and technical skill mix and develop end-of-program goals. And this led us to transform clinical experiences to immersion experiences, getting away from this acute care focus. We looked at transitions of care, we looked at the foundational skill set, and we looked at caring for people along the continuum: primary care, ambulatory care, communities, churches, libraries. Again, wherever we could find the people, that's where we wanting to create immersion experiences. And many of the sites didn't have a registered nurse. So we actually hire immersion educators to go with our students. We previously called our clinical faculty clinical adjuncts. They're now called immersion educators. We're working with a number of clinical reasoning tools and also working very closely with our practice partners. So then, rather than being focused on acute care in the hospital, we moved to a series of immersion experiences. And for example, in the Immersion 1, Wellness, Prevention, and Maintenance, each week, students have 2 days devoted to immersions. And so they may be 1 day in an acute care setting, and then the second day in either a primary or ambulatory care experience. So the students are no longer doing blocks of time, and they're no longer doing med-surg to pediatrics, OB, community, and complex care. So this is all coming together over the continuum of their immersion experiences. And then the immersion experiences are across the lifespan and across the care continuum. And some may ask, where's like mental health, where's community? Both mental health and behavioral health concepts are embedded throughout the curriculum, and community and public health concepts are also threaded throughout the curriculum. In addition to the immersion opportunities, students also have required experiential and service learning work that they do. And this slide just lists some of the opportunities the students have at the Broad Street Ministry, where they've created a mobile wellness center, the Philadelphia Episcopal Cathedral, where they created a health education center, and then they're working with the Refugee Center at the Nationality Services Center. And each of these is a bit different, and we work with the organizations to let them identify what is the service, what are they looking for in respect to what this immersion opportunity could be. And so some lessons learned were, think big, and we started small. We really were rethinking the current clinical sites for other opportunities. We identified champions and engaged them early. The transition from clinical faculty to immersion educator, as well as our full-time faculty to the new curriculum, faculty development is critical. It was also critical to provide education for the clinical bedside nurses with the new curriculum, as well as organizations that we were wanting to partner with in the community in primary care as well as ambulatory care. Because as Danuta said, many of the sites, you can't typically send a group of students there. They may be willing to take 1 or 2, it might be 4, but it won't be 8 to 10. And so that takes some finesse in talking with these new immersion sites to create that opportunity and to be able to address a need that the organization has. And so the curriculum uses a multidimensional approach that focuses on establishing and expanding upon academic practice partnerships with acute, ambulatory, primary care, and community care sites. This curriculum was begun with our one-year accelerated students in May of 2016, and we introduced this to our traditional pre-licensure students in fall of 2016. And this photograph, as part of the new HERE curriculum, we created the HERE Fellows program. And so we have 70 fellows across all our BSN programs. And in addition to receiving scholarship funding, these students serve as peer-to-peer learning collaborators. So this is just a short snapshot, some food for thought on the future of nursing education. Thank you.
Great. Thank you so much, Beth Ann. That was a wonderful presentation, and thank you to our other presenters as well. I think you all did a nice job of tying the two presentations together. So as Peter mentioned, we'll be having some time now for questions and answers from the audience. So if you haven't already logged a question, head on over to the section of the toolbar for that, and then you can type your question and we'll get to as many as we can. Traditionally, I like to kick it off with Peter having the first question to ask. So Pete, if you're ready and have a question, I'd like to start with you.
Christy, thanks, but I'm going to penalize myself for doing such a poor job of getting our webinar started. So I'm going to just step back and let somebody else go ahead and ask that question. I think we must have a few questions that are already posted, right, Christy?
We do. I can start with one.
All right, thanks.
The first one is a housekeeping question. Do you ladies mind if I post your slides onto our website?
Yes, you can post the slides. This is Beth Ann. You can feel free to post the slides on your website, yes.
Okay, great. And let me get back.
And for us as well.
Okay, great.
I was just going to say for.
Let me get my toolbar pulled back up here. Apologize. Okay. All right, I have a question. How do you see policy impacting, either positively or negatively impacting the ability to expand nursing primary care curriculum? How do you think that works in your favor or against you?
The question is how policy affects?
Sure. How do you think health policy or even state, local policies, how do those things work in your favor, and then how do they work against you?
So I can address that. This is Danuta. You know, in Washington State, it has been mandated that we include these concepts in the curriculum. So when you're statewide, and other states as well. So actually, like at the state level, the policy is that it's recognized that it is important, then it's like much easier to implement. I believe, because you are mandated. On the other hand, like the places where there's no policy that would mandate these concepts in the curriculum, it might be more difficult. Like we are coming from long tradition, like more than 60, 80 years of undergraduate curricula that were primarily like acute care focus, and typically there was maybe like one community course like in the curriculum to address these concepts, and so there's the whole culture change. So regardless of policy, like there are some other barriers, I believe.
Hi, this is Beth Ann. I'm in the state of Pennsylvania, and we don't have any mandatory regulations related to this. And when the faculty decided they wanted to, create a new curriculum based on the evidence, based on national reports, we worked very closely with our State Board of Nursing, nursing advisor, as all along, because in our state, our curriculum must be approved by the State Board of Nursing. And so we just worked closely with our nursing advisor so that when it came time to submit the document to the State Board for their review, and we were fortunate for approval, that she was aware what was coming and what it was all about.
And great. This is Ellen Marie. I'll just say from the federal perspective, especially for payment, in a fee-for-service system where typically the physician has been reimbursed for the services that he or she does in a very specific setting, when that's the way that healthcare was paid, it was very limiting to just those that were able to receive billing. When we're moving now towards more population-based payment, where we pay based on if the patient's actually getting better, that certainly bodes well to a more team-based approach as well, which would certainly provide the opportunity to have nurses be able to start to function to the full extent of what they can do in all sorts of settings.
Great, thank you. I have another question here. One of the challenges is engaging students in this change of thinking. How have you handled this at Jefferson?
Okay, this is how do we handle this at Jefferson? So I would say students who are thinking about nursing, and I'll risk making a generalization. They're pretty savvy shoppers, and they know what they're looking for, and they know what they're choosing nursing. They know what's happening in healthcare, and we were pleasantly surprised as we were rolling this out, what we were going to be doing at our information sessions and open houses. Students were pleased to see that the curriculum was changing and moving away from the hospital to be more aligned with what was happening in healthcare delivery. So we were pleasantly surprised, because we thought we were going to have need to do marketing and communication to convince students that this was an important step forward. And the students have really enjoyed the opportunities they've had in their immersions and in creating new immersions, where again, perhaps there is no RN, but our faculty say, wow, if we could create that role at those immersion sites, we feel like we're blazing the trail.
So I wanted to add to that, since we also started the curriculum that is based in primary care in Seattle, in my school. Exactly the first introduction of this curriculum was to potential students, so at the information session, so they could make informed choices. And at our place, it wasn't very easy at first, like when the curriculum was rolled out, like with the students who already like were in the program. Now it's like absolutely like much better. And I must say that there are some primary care sites now that are asking for our graduating students for their final clinical experience, and then to hire them on because the experience was so good. But unlike in Jefferson, it wasn't very easy for us at first. It's getting much better.
And I just want to add something. As we were identifying new potential immersion sites, this word of mouth spread, so that we started at the Broad Street Ministry. People who were there had colleagues at another nonprofit organization. They contacted us and said, oh, could your students come here too? So this word of mouth really helped us expand and get these opportunities for our students.
Great. Those are all great answers for that question. I have a similar question, but maybe from a different perspective. So how can we overcome faculty's hospital-centric mindset and the perception that NCLEX sets the parameters?
Well, this is Beth Ann. I was very fortunate to have a very forward-thinking faculty, so I can't address that. But as far as NCLEX goes, NCLEX is not, it's a myth that it's acute care focused. So I think some of that is a self-perpetuating myth. And I think if you look at the blueprints, which change every couple years, I think if we're graduating students who can reason and critically think, that concept, whether it's happening in the hospital, in the home, or in primary care, the students are prepared to sit for the NCLEX.
So this is Danuta, and I would agree with everything you said, and also wanted to add that if you don't have at your sites maybe many faculty who are convinced that it's a good way to go, start with the leaders, start with those who are early changers and they are willing, and others are going to follow because the students are going to recognize that experience is very, very good. In our curriculum, we got rid of one of the med-surg courses. We used to have 2, now it's down to 1. So that seemed to be challenging to some. But, even our medical surgical faculty, it's like a mindset that it has to change, and they changed it, and they can see benefits, and they even for medical surgical experiences, they can be in the ambulatory care setting, and students also learn a lot, and there was no any negative impact on their overall learning and passing NCLEX as well. So it worked out.
Great. I think we have time for one last question here. How do you address the differences in roles of registered nurses in primary care and advanced practice nurses in primary care?
It's Beth Ann. So the various roles, you know, we first start with the role of the RN and what those scope and standards are relative to our State Board of Nursing. But I think, as we've seen in Ellen Marie's presentation and Danuta's presentation and what national reports are telling us, the role of the nurse, the registered nurse, I'm not referring to the APRNs, the role of the registered nurse is really broad in scope, and that's really what this Macy conference was about, in looking at the role, and really, because it's, again, so traditional that it's been in acute care. But as Ellen Marie showed us, you know, we're back to the future. You know, where we're trying to get to now is where we were at the turn of the century. So we say new roles and enhanced roles, but really we're going back in history to say, okay, there was something to wellness, primary care, public health in the community. And again, the differentiator is there are scope and standards that differentiate the roles of an RN versus the roles of APRNs.
And thanks, Beth Ann. And I would just, this is Ellen Marie, I would just add that Danuta and I, when we were part of a project that kind of predated this one, we had the opportunity to interview, I think, about 18 different practices that were using using RNs in primary care. And 2 of them were nursing centers where there was the only providers were primary care providers were nurse practitioners. And one of the things that was clear is it was that diagnosis and treatment that was clearly the role of the NP. But when someone already had a diagnosis, and most often it was a chronic illness, managing that chronic illness was something that the nurses did so well, and that did not take an RN, an NP to do that, and really started to tap into some of what nurses really like to bring to the practice. There was also triage. There was also a lot of quality improvement activities of how the practice was actually running. There was, in the paper that we did, which is also in Nursing Outlook, we identified about 6 different roles that the RN had, supervising medical assistants, and many of those roles that occurred in primary care could be done by an RN. And I think in an era where we're hoping that everyone practices to the full extent of their training, it was clear that there were certain things that only the NP could do, and there was lots of things that the RN could do, and they could work really nicely together.
Great. I think that's an excellent place to stop for today. I know we had other questions and apologize that we aren't going to be able to get to them today, but I do want to thank our presenters for taking time out of their very busy schedules to talk with us about these topics today. And also thank you all for attending. We're looking forward to a busy spring lineup of webinars, so we hope you'll stay tuned for more information on those. And happy holidays from the center.
Thank you, Christine. Thank you, Peter.
Okay. Bye-bye.
Thank you.
Bye.
Thank you for helping to thank you for helping to put our cold weather into context. You out there in Montana.